Hi, I'm Kate Foreman. Thank you for joining me for my talk, Genetic Counseling for Predictive HD Testing, Expanding Access. I have no financial disclosures. I will briefly discuss HR 2144, the Access to Genetic Counselor Services Bill, which is currently in committee in the House, as well as its Senate companion, S 1450. Any opinions on that legislation are my own and are not intended to represent my employer. I would also like to disclose that November 4th is Genetic Counselor Awareness Day this year, so I'm very pleased to have an opportunity to represent my profession today here at HSG. Perhaps another disclosure I should make is that I consider myself fairly new to the HD community. I have been a genetic counselor in a cancer and adult genetics group since 2009, but I saw my first patient seeking HD predictive testing in 2017. And I consider myself very fortunate that I had that opportunity and have been able to continue to walk with the HD community. I do feel like HD was very well represented in my genetic counseling coursework. Along with Fragile X, it's a poster child of nucleotide repeat disorders. We had case examples that we worked through about HD. Even when we were learning about Bayesian statistics, we did problem sets using age-related penetrance to adjust a pretest probability of a positive result. So we saw HD a lot in our classroom coursework, but our opportunities to work with the HD community in clinic were sparse. I spent only one day shadowing in an HD pre-symptomatic testing clinic. And while I was there, I had the opportunity to see 2 pretest appointments and 2 return of results appointments. But again, this was just shadowing. I wasn't practicing as a genetic counselor in those sessions, and many of my classmates got far less. After school, I felt like there was similar sparse exposure to HD. I'm a member of the North Carolina Medical Genetics Association, a professional genetics association in my state. And I do remember a handful of meetings where the topic of HD came up, once in the setting of drug discovery and another time to screen the documentary Twitch about pre-symptomatic testing. I had clinical work that involved familial ALS, spinocerebellar ataxia, and familial Alzheimer's disease and dementia. But I wasn't seeing Huntington's disease patients. And this was actually because of an institutional quirk that the HD pre-symptomatic testing protocol at my institution was housed in pediatrics. It actually predated when we had an adult genetics group. But all of that changed with an email. The genetic counselor who had been doing the HD predictive testing in our community left and took another job. There was a planned handoff to another genetic counselor in her group, but due to changes in departmental leadership and referral patterns at that practice, practically it was difficult to impossible for that counselor to actually serve the needs of the HD community. So she had to step back from that. So in 2017, the founder and medical director of a Huntington's disease support group from our state reached out with this email. This medical director was working with a patient, and the patient had really spent a long time considering the timing of their testing and getting themselves prepared for the best possible outcomes. They already had had psychiatric evaluation and had a long-term relationship with a psychologist. They were planning to even get neurocognitive testing done. So everything was in place, but they were unable to find anybody to order the genetic testing that was kind of the goal of this plan and process. So the pediatric genetic counselor reached out to us, since we're the adult genetics group, and said, would we be able to do this? And the answer was absolutely. We talked more with that medical director and learned that they had made calls across the whole state and not been able to find anyone willing to order this testing. And our group felt like this was something that we had to remedy. This was an access issue that impacted citizens of our state who needed a test that was important for them. But we started thinking about, what is the best way for us to do this, and what are the access issues? I set to learning at that point about the HD testing protocol. This is something that's familiar to most of you, so I won't spend a great deal of time discussing it. But the HDSA developed protocol is a multi-step process. It's not just the testing, although that's often the focus of the patient. It typically starts with a telephone contact where the prospective patient learns about the testing process, what's done to protect confidentiality and the limits of that confidentiality in terms of what goes in the electronic medical record. They learn about costs and insurance, both the potential for insurance coverage of this protocol and implications for things like life insurance. Then they would follow with an in-person visit, including genetic counseling and possibly many other components, a mental health assessment, a neurologic exam, even social work evaluation. If they are still interested in proceeding with that testing, they go through an informed consent discussion and ultimately get a blood draw. The results are returned at another in-person appointment when you arrange the plan for follow-up as well as disclosing those results. And then a follow-up check-in happens sometimes later. This could be in person, but it's often by telephone. And it's a formal check-in and a time to follow up on referrals and those sorts of things. I do want to point out that in learning about this process and implementing it at my institution for the first time, it is easy to minimize that initial phone contact. It seems like a relatively simple formality to the process. But I have found that a lot of the work of the predictive testing protocol happens there, and that phone call often ends up being as robust as the visit one. It's where I'm first learning about this patient, what their experiences with HD have been, and why they've chosen now as the time to learn more or proceed with predictive testing. Importantly, that's also time that's often not reimbursed, so that's not billable time. And we may have phone calls with many patients who don't ultimately schedule in-person appointments. In learning about this process and beginning to implement it, we were still thinking, why is genetic counseling for HD, particularly for predictive testing, hard to access? We have quite a few geneticists and genetic counselors in our state, so it was surprising to learn that it was a hard service to find. So we were thinking about things like institutional barriers that might make it difficult to build that pre-symptomatic testing team, the costs of testing and how they might deter people either from setting up a protocol or patients from going through it. The specialization of genetic counselors and limits to genetic counselor autonomy, which I'll talk a little bit more about in a second, as well as the confidence, the self-efficacy of genetic counselors who may have learned about HD but had little clinical exposure to implement these protocols. And finally, geography is also a concern. With respect to institutional barriers, we found that we had some of those right at UNC. Obviously, the first was that we had a history of a robust pre-symptomatic testing protocol that because it hinged on one key staff member, when that person left, there wasn't an HD advocate at the institution, and that process, that carefully planned process, fell apart. But when we worked to reestablish it, we reached out to the partners that had previously been working in this multidisciplinary setting, and there was no longer staffing or interest or just willingness to provide mental health component in a multidisciplinary setting. Similarly, in reaching out to neurology, we weren't able to identify a staff person who could either be in clinic with us when we were doing HD pre-symptomatic testing or be available on an on-call situation. So that caused us to make some adjustments to the HDSA described protocol that work best for our institution. That includes having mental health totally separate from our clinic. This is sometimes a challenge for patients because they have to engage in a mental health provider outside of the institution, but we do everything we can to help with referrals. We talk to those mental health providers to get them caught up on the issues surrounding HD, including referring them to resources like CME for HD for their continuing education. And so we have found that although initially cumbersome, this is meeting the needs of our patients. And some patients develop long-term relationships with those mental health providers, even if they thought it was just a check on their checkbox towards going through with the testing protocol. I work with MD geneticists, so although we don't have a neurologist in clinic, they are able to conduct a brief neurology exam. But we have had times where there was concern that a predictive testing patient might actually have early symptoms and become a confirmatory testing patient. And without neurology built into our clinic, we've had to have a shared discussion with patients and determine whether a stop to the predictive testing process for referral to neurology may be in their best interest. Next come the predictive testing costs. HD testing is becoming increasingly affordable, but patients tend to think of the cost in terms only of the genetic test itself, where in reality that whole protocol has costs associated with it. This can include the genetic counseling, the neuro exam, seeing the mental health professional, and even a second appointment for the return of results. Victor Sung's group at UAB recently reported on predictive testing costs at HD Center of Excellence. His group had an abstract at the International Parkinson and Movement Disorders Congress. And they reported that an average cost was around $11,000, but this varied greatly from $275 to over $3,500. And I do think costs are a barrier to patients. I have had that initial telephone call with a patient who described seeking out HD predictive testing years ago, but being turned off from the process and ultimately choosing to defer when inquiring about cost and being told only it could cost a few $100s or anything up to $5,000 and giving no more specific guidance. It also may be a barrier to genetic counselors and genetics teams offering this testing, because if they feel like they can't describe those specific costs, they may feel like they're not suited to provide them. The GC factors, when I talk about specialization of GCs and limits to genetic counselor autonomy, I mean that genetic counselors in states like mine without licensure and in some states with licensure, genetic counselors are often practicing under a physician who co-signs their notes and orders. So a genetic counselor whose main specialty is cancer may be able, interested, and willing to see patients for predictive HD testing. But if the physician they work under is an oncologist, that person might not feel like it's appropriate for them to supervise that process. So GCs can't always completely decide what services they're going to offer within that relationship. And there's this interesting dichotomy of being very well academically prepared for Huntington's disease, but perhaps having limited clinical exposure. And I sometimes think that the extent to which our genetic counseling coursework highlights and focuses on HD and that special protocol with a multi-visit model that doesn't happen in many other disciplines of genetic counseling can make it seem scary or like it's inherently harder or wildly different from other sorts of genetic counseling. So I think that genetic counselors may feel like they couldn't do a good job, and that prevents them from either offering or starting this process. Fortunately, there are resources. So I benefited from CME for HD and from the HDSA's Genetic Counselor CEU program when I was learning about how to do this. Finally, geography. At this point, there are 2 places in North Carolina, my state, where you can get HD predictive testing through a genetics clinic, and they are marked with the stars. There's about 3.5 hours of road between those 2 locations, and you can see that we're the easternmost site, and we're very central in this state, which means everybody from the east is probably driving 2.5, 3 hours one way to see us. That being said, people who are interested and motivated to get this information, for the most part, were doing that. They were coming to see us. And we were fairly happy with the protocol as we had designed it. And then COVID happened. So our first question was, during a pandemic, should we continue to make access to pre-symptomatic HD testing available? We often tell patients, we're not trying to be a gatekeeper to your testing, but we're trying to make the circumstances around your testing as optimized for a good outcome as possible. And we wondered if that was even possible during a pandemic. The referrals slowed down, but they did not stop coming. And so we quickly decided that, yes, we should find a way to offer this. And that was going to be by telehealth at our institution. We weren't going to be able to continue in-person appointments. So we wondered, can we offer pre-symptomatic HD testing via telehealth that's non-inferior to the usual protocol and the HDSA protocol that focuses on those in-person communications? So to answer that, the first thing we did was ask the experts. I reached out to some genetic counselors in HD centers of excellence, some genetic counselors that had participated in that genetic counselor CEU series that I had taken, and asked their opinion. I'm not going to share their comments specifically because they weren't aware that they were talking in a way that their comments might be shared. But suffice to say, they did not look at me like the idea was wild. They shared that they too thought that continued access to the service was important, and most of them had already adapted to providing some sort of telehealth in the pandemic situation. I also sought out medical literature. To my surprise, there was actually a publication shown here in 2013 that discussed positive findings regarding offering telehealth for the predictive testing process. And I appreciate that this figure is really small. I won't go into detail on this paper since it is published, but there was high satisfaction with the telehealth process they devised. 14 out of 14 people who went through the process were satisfied with it. 14 out of 14 said it saved them time, that it saved them money, and felt that their privacy was respected, even though it was a telehealth process. I do want to point out that this particular group's protocol involved partnering with a local physician, and that local physician actually did an in-person disclosure of results in most cases. So it's not perfectly analogous to what we were doing all telehealth in the pandemic, but it was still good to see these positive outcomes. And importantly, 3 out of 10 people, that should say 14, excuse me, 3 out of 14 people reported that had telehealth not been available, they would not have traveled for an appointment, which suggests that those people either would not have gotten the testing they wanted, or maybe they would have accessed it from somewhere that didn't have as much experience with this HD testing. I also looked to literature from other fields of genetic counseling. And I work in cancer genetics, so I was interested in kind of what cancer genetics has said about telehealth. And there's a great deal of literature about the non-inferiority of genetic counseling by telehealth, particularly if that includes video visits for cancer genetics. And interestingly, there is also data about how much interaction has to be face-to-face, because even virtually, if you're including video, that has some similarities to a face-to-face appointment. And it turns out that in cancer genetics, we used to have that multi-visit model with an in-person return of results. But over time, it has become much more common to do return of results just by telephone, and patients are satisfied with that process, and there are not poor outcomes. So the take home here, telehealth has sweet and sour. The patient seemed more relaxed. I cherish a memory recently of returning an HD result where my patient had her pet dog in her lap while receiving the news, something that wouldn't have happened in clinic. We have the opportunity to include physically distant support people. We initially thought that might be a barrier. If the support person wasn't in the patient's home, would they be able to adequately support them or recognize signs of distress? But we had one patient go through the process who was able to reach out to their childhood friend, the person who was with them when they learned about their parents' HD diagnosis, who had actually seen their parents' symptoms, and use that person as a support person, as opposed to a local friend who had much less familiarity with how HD had impacted them thus far. Obviously, no travel time or travel cost for our patients, which is a benefit. As a genetic counselor, it's hard to change. It's hard to let things go. And there have been some sours. I find my use of visual aids to be more challenging. Sometimes the visual aid blocks the patient's video, so I can't see their reactions as much. Co-counseling is a challenge. With the delay in video, we try not to speak over ourselves, which is easier in person. You lose some nonverbal cues. And I find that patients who have a normal result are a little less patient in their return of results visit, whereas people who've come into an appointment do expect some conversation even around a normal result. But for the most part, the sours are inconveniences and don't outweigh the benefits that we have seen. So as promised, I wanted to mention the Access to Genetic Counselor Services bill. This bill would provide Medicare provider status to genetic counselors. This would also allow us to be directly reimbursed at a proposed 85% of the physician fee schedule, and allow for genetic counselors to offer telehealth and have that be reimbursed. So I think that has the potential to directly benefit some of these barriers. In terms of cost, if we are recognized by Medicare, other payers may follow suit. And so insurance might bear more of the costs of this process. This could help with those specialized GCs who might not have a physician partner willing to take on HD, but could do it themselves. And with telehealth, it would solve some of the geography problems. Just a bill recognizing genetic counselors as service providers would not solve all of the hurdles. And of course, if you are in a state with a genetic counseling training program and you don't already have some sort of relationship with that program, I encourage you to reach out and see what you can offer to those students, because I do think some hands-on experience goes a long way in getting more providers comfortable to do this testing, and more bodies will be able to serve more testing. This is just a short list of organizations that have already signed letters of support for HR 2144. And with that, I'd like to conclude acknowledging Debbie Keelan-Fuller, who started the HD testing protocol at UNC and who was a great resource to me as we tried to restart it, my genetic counselor and MD colleagues, and all the clinicians who created those CME for HD and HDSA genetic counselor CEU resources that I learned from. This has just been my experience and my opinions, but I do want to point out that a genetic counseling graduate student, Wes Solom, interviewed many genetic counselors about the impacts of COVID on their HD predictive testing, and he has an abstract here in the community impact section. So if you've been interested in my perspectives but want to hear more from a broader group of genetic counselors, please check out his abstract as well. And with that, I am able to take any questions. Thank you. All right, thank you everybody for spending some time this afternoon with me. I am going to jump into the comment and question section with a comment from Samuel. He observes, even though your experience in GC school using HD for teaching purposes is common, many GCs are just not comfortable with pre-symptomatic testing in HD. There are also few HD-focused mentors in the GC world. And I'm going to agree with that and endorse it again. I didn't use this term in the presentation, but if you're in the genetics community, you'll have heard the term genetic exceptionalism. That inclination to treat genetic information as different from other sorts of health information. And there is great debate about the extent to which we should do that. Should genetic test results be siloed from other test results in the medical record? Or are we actually doing more harm than good by treating that information as special and thus making it less accessible to people when they might need it for treatment planning and those sorts of things? And as genetic test results have moved in the cancer world, for example, of knowing, well, great, we're at risk for cancer, but there's nothing we can do about it, to increasingly having prognostic and treatment implications, there has been a movement to treat those results with less exceptionalism. And I think within the genetics community, we have a little bit of Huntington's disease or neurogenetic exceptionalism, where we do kind of put on a pedestal conditions like HD, which make it challenging to jump into this area. And I do think there are HD mentors in the genetic counseling community. Those are the folks that I reached out to when I was like curious about telehealth, and they'd presented the CEU material in cooperation with HDSA. But they can be hard to find and access if you don't know those networks. So I think that's changing. And one of the reasons this whole talk was very important to me is as therapeutics become a possibility for asymptomatic or early onset HD in the future, I expect more people will be seeking pre-symptomatic testing, and that will cause us to confront, again, how we handle this process and how we handle this sort of information. I'm going to combine a couple of other questions together. So someone had a question about at their institution, they have access to an HD Center of Excellence that has enabled them to get good and cost-efficient testing for their patients. But that group requires the pre-test and the post-test counseling, even in cases of affected individuals where the neurologist is highly suspicious of HD. And they wondered about that. And then I had another question about other anecdotes from HD telehealth. And I'll just say that at our institution, we don't handle it the same way. So I can't really comment on the rationale for that group wanting to do the pre-test and post-test for confirmatory testing. Typically at our group, if the neurologist has a high suspicion of HD, they facilitate that testing. And while the testing is pending, they put in a referral to us for post-test counseling. And a positive HD post-test result is triaged as a priority. So it jumps a little bit of the wait list to get in to see us. And that directly relates to one of my other HD telehealth anecdotes. It's again a sweet and sour. I had such a patient. I had a patient who was recently diagnosed with HD by their neurologist and referred for a post-test appointment with me. And unexpectedly to me, they had 14 family members sitting in their living room, or some also joining by phone on speakerphone, all excited and ready to hear what I had to say about this diagnosis that was new to them. So for the family, that was a benefit. They didn't have to play the game of telephone. They could all be present for the communication about the result. For a provider, it was really difficult for me to manage that many people. I've definitely had families come to clinic, but I don't think I've gotten beyond 6 or 7 people all trying to get into my small clinic room. But patients have a little bit more ownership of this process when it's their own home in their living room with who they think to invite than if they're going into a medical center. And that encounter actually spawned a group of 4 of those family members later coming for their own predictive testing. So let's see. There's another question about challenges of giving positive results virtually. I personally have only had one positive result since going fully telehealth, and it had no more challenges than I have seen in person. Again, I briefly mentioned in the talk, I've really had more problem with the negative results, people being like, okay, great, can I sign off now? Whereas they're more willing to engage in a post-test discussion where we talk about the fact that your happy feelings now may not stay with you, that there can be ebbs and flows to how you feel about your normal result. Some of the things I worried about, though, in terms of positive results were, what if someone has a really significant adverse reaction? In 12 years of being a genetic counselor, I have had one patient in clinic who I felt like was a danger to themselves. And we walked down to the emergency room. That didn't happen to be an HD patient, but that's a resource that is in the building with me when I'm in clinic. Whereas if a patient was 3 hours away from me in their living room, I have worries about how to get the best care for them. So we also ask patients to sign forms that allow us to share their information with HD support organizations, with social workers at our institution and at HD groups to reach out and do kind of wellness checks with them. So that's one way we tried to prepare for that bad outcome, which fortunately we have not seen yet. I do have a few other questions that I'm not going to have time to answer because there is another talk starting right now at 2:45. But you have my contact information or can send me a chat if you would like me to address your question. And I will try to reach out to you if I see your question and can find you. Thanks again for spending your time with me this afternoon.